Hello and welcome to Pulmonology Read Aloud, a channel about pulmonology topics. Today, I'm going to present the second part of the patterns in lung disease. My name is Dr. Anshu Maneja Arora, and if you haven't seen my previous video, then you can see the part 1 of this series, which talks about the lung disease patterns on the chest CT. So let's get started. In the part 1 video, we had discussed about three main patterns: the honeycombing pattern, cystic pattern, and nodular pattern, and also touched upon the tree in bud pattern. In today's video, we're going to talk about mosaic attenuation, ground glass pattern, and air trapping, along with septal thickening. Now, all four of these are oftenly confused, and as a clinician, I'm going to give you a clinician's perspective on reading these patterns on a chest CT. So the first pattern that we're going to talk about is the ground glass pattern. Now, ground glass, as you can see, is a hazy glass. So it is a glass wherein everything is not exactly transparent and very clear, but it looks hazy. It's hazy, yet you can see what is behind. So like in this picture, you can see the person's fingers behind the glass, but you cannot see them very clearly, but you can partially see through it. So what is typical of the ground glass pattern is that though it is hazy, you can see the underlying vessels and you can also see the underlying bronchi. So nothing is obscured there. But it is a very non-specific pattern and it has many differentials. So this is the ground glass, but I can see the bronchi and the vessels behind it. This is a ground glass, but I can see the bronchi and the vessels behind it. So this is all the ground glass pattern that we are seeing. The causes of ground glass pattern are basically because of the etiology. And ground glass happens whenever the alveolar spaces get filled. So to understand if the alveolar spaces are filled by cells, excessive cells, because of fluid as in edema or congestion, blood as in a hemorrhage, protein as in pulmonary alveolar proteinosis, or because of thickening of the alveolar walls or interstitium because of certain ILDs, then the ground glass pattern is visible. The most common causes for a clinician's perspective are infections, pulmonary hemorrhage, organizing pneumonias, pulmonary alveolar proteinosis, and ILDs like NSIP and DIP. These would be the most common things that would come to my mind when I see a ground glass pattern. Now, ground glassing can be diffuse or it can be localized at a place, and that really helps us narrow down the differentials for ground glassing. So in this case, we can see that it's almost diffuse in the lung. It could have happened because of an acute infection, in this case an acute viral episode as well. But here we can see that the ground glassing is mostly subpleural, it's mostly peripheral. So these can differentiate between various. So the distribution is also something that is very important. The spatial distribution of the ground glass opacification in a lung can give us more clues towards the differential in that case. So for those ground glass opacities which are more in the upper zone, the common differentials include hypersensitivity pneumonitis, bronchiolitis, and sarcoidosis as well. But in the middle and the lower lung zone, it could be the onset of ILDs like NSIP, it could be pulmonary edema, so dependent opacities, even in hemorrhages, as well as in aspiration syndromes. If the ground glass opacities are more peripheral, then again they signify ILD processes like NSIP, DIP, organizing pneumonia, eosinophilic pneumonias, and if they are more central, they may happen because of hypersensitivity pneumonitis, alveolar hemorrhage, PAP, pulmonary edema, or aspirations. So the location and the distribution is what is important whenever we see the ground glass opacification. The second term that's very confusing for most people is air trapping. Now, air trapping has been classically used for identifying small airway disease, and it's believed that air trapping will happen when there is a focal retention of air or gas in the lung. So, essentially, air trapping will occur whenever there is retention of air distal to any obstruction. So, we can clearly see in this scan as well, there is a huge localized area of air trapping. So, probably there is some obstruction at the level of this bronchi, and so there is air trapping at this level. But to assess air trapping, an inspiratory scan may not be sufficient in a lot of cases. So, if we are suspecting air trapping, we might need some form or some degree of expiratory scanning, but it also depends on the patient's own effort of expiring and inspiring that we'll be able to see the classic pattern or not. When we are trying to detect air trapping, there are certain features on a CT scan that can be helpful. To me, the three main components would be one, that the trapped areas have a relatively high attenuation on the expiratory scans. Now, normally, whenever we have a fully inflated alveolus, the average attenuation seen is minus 850 Hounsfield units. If your patient expires very well, the average attenuation will increase by 150. That means it will look more dark by 150 or more black by 150. But in cases of air trapping, there are newer indices and even quantitative measures that have been described where the expiratory air trapping can be measured, or the expiratory density rather can be measured in accordance to the inspiratory density, and the EI ratio can be obtained. However, it's not a validated ratio. It does not have validated cutoffs between normal and abnormal, but to speak so, anytime when the expiratory lung density is more than the inspiratory, it would suggest air trapping or trapped areas. The second is that the volume would not change much. So any area with air trapping will not lose much of their volume on expiration. So it would be against an atelectasis. You will have retention of the volume but more black appearance. And air trapping usually has a sharp delineation at the border of the secondary pulmonary lobule. Let's again look at this picture. It has a sharp delineation. It's more black on expiration, and so it's air trapping. One of the ways to check for expiration is when you're looking at the trachea and you would see the bowing of the posterior tracheal wall in the main trachea, then you can assess whether the patient has done an expiration. Coming to the other concept, which is mosaic attenuation. Now, mosaic attenuation refers to several different radiological signs together. So there may be low density areas, there may be high density areas, there may be preserved areas, there may be air trapping. And classically in hypersensitivity pneumonitis, mosaic attenuation has been described as the head cheese sign. So you may be seeing different patterns and different densities. But mosaic attenuation is not limited to hypersensitivity pneumonitis. The Fleshner Society of Radiology defines mosaic attenuation as a patchwork of regions of differing attenuation seen on a CT of the lung. So, when we are looking at mosaic attenuation, we may see certain areas with a particular density, others with another, intermixed with different densities. So here you can see a white density and a black. So white and black or gray and black shadows which are interspersed in the lung parenchyma, and these are mosaic attenuation. So mosaic attenuation is a general term, a descriptor term that shows that there are geographic areas of different lung attenuation in the lung. But does mosaic attenuation refer to whether the gray part is normal or the black part is normal? Whether the opaque lung is normal or the lucent lung is normal? The answer is no. It just implies that one part is abnormal, and it is our task to find out which is most precisely the case. Again, in this image, you can see there are areas of black and gray which are in several parts of the lung. So, this is mosaic attenuation, a non-specific descriptor term which has to be further classified. Another main problem that people make is the differentiation of mosaic attenuation and mosaic perfusion. So, mosaic attenuation is not synonymous with mosaic perfusion, and although they look identical, mosaic attenuation comprises of mosaic perfusion rather than the other way around. So, if we're talking about mosaic attenuation, just to quickly understand, mosaic attenuation comprises of dense and lucent areas of lung, but it does not clarify which part of the lung is abnormal. The denser area or the whiter area, in case that is abnormal, then it would be the ground glass pattern which is abnormality in the lung. And if the lucent area or the blacker area is abnormal, then that is mosaic perfusion. So it could be mosaic perfusion causing more blackness, and the rest that we see is just the normal lung, or it could be the ground glass which is abnormal and the rest black that we see is the normal perfused lung. So, to simplify, mosaic attenuation is a patchwork, and amongst mosaic attenuation you'll see two densities, and they could be because of mosaic perfusion or in the form of ground glassing. And it is whether the areas are hypoattenuated, which look more black, or the lung areas look more white. That differentiation decides the causes of mosaic attenuation. If it's simpler, I'll just summarize it again to make it more clearer. Airways usually cause more ground glassing, and mosaic perfusion is usually meant to depict vascular diseases. However, in the next few slides, I'm going to tell you that that's not exactly a foolproof way. So normally we perceive that if it's ground glass, airway involvement, if it's perfused poorly, it's vascular involvement, but sometimes it could be more complicated. Let us understand how we can differentiate these two main components of mosaic perfusion with ground glassing. Now, I told you again and again that mosaic perfusion refers to abnormally lucent lung or black lung, and ground glass refers to the abnormally opaque lung or white lung. So, there are certain features that favor that the mosaic perfusion pattern or the black part is the abnormal part. Few of these features are sharp borders between the two regions, smaller vessels in the lucent lung, and air trapping on expiration in the areas that were earlier lucent on inspiration, which can happen in the small airways component of mosaic perfusion. If you're confused, please don't be, because I will clarify this third point later. Essentially, what I want you to understand is that mosaic perfusion has sharp borders, lucent black areas, and remember that smaller vessels in the mosaic perfused part. So one good way of identifying is looking at the vessel size, because this distinction between mosaic perfusion, ground glass, which one being abnormal, is still having a lot of pitfalls. Normally, smaller lungs or the abnormal lungs or the smaller airways may depict abnormal part. However, if we just describe it on that basis, it may become confusing. So one way is looking at the vessel's size. In case of mosaic perfusion, the abnormal lucency is because of vascular oligemia, or there is a shunting away of blood from that part. So the vessels will look smaller, and the number of the vessels in that part will also be lesser. Keep that in mind when we come back to mosaic perfusion, but let's try and understand what happens in ground glass instead. In ground glass, the abnormal dense lung has vessels which are generally equal throughout. So if you look at the vessels, there will be no strict differentiation and you would see them more equally placed. Now, in case of mosaic perfusion, the vessels will be much less. So let's look at this area. There is a gray area and a black area. Now, if you look at it, the number of vessels in the black area is definitely much less than you can see in the gray area. So it's actually the black area here which is abnormal and the gray area is the normal lung, and this is called mosaic perfusion. Here again, very clearly, you can see more dense vessels in the normal zone and much less vessels in the black zone. More vessels in the normal zone and less vessels in the black zone. Mosaic perfusion. So mosaic perfusion is defined as a patchwork of very sharply demarcated regions with decreased and increased attenuation, decreased vascularity in the absence of an infiltrative lung disease or a small airway disease. Now, in these two images, the sharp border is clearly visible between the opaque and the lucent lung, and the larger vessels are normal in the normal lung, and in the other lung we can see that the vessels are less. So mosaic perfusion essentially can occur because of vascular disease, sorry for the spelling, obstructive vascular disease, but it can also occur in small airway disease because both the cases is vascular oligemia. There is a shunting away of blood from both these spaces. Now we know that small airway disease is typically characterized by air trapping. So one way in differentiating is whether there is air trapping or not, because the hypoxic vasoconstriction will shunt away the blood, but the vessels will also be less. They will be less numerous, less perfused, and the lung will appear more hyperlucent. In an obstructive vascular disease, the vessels will be less and obscured, but it will happen because of the vascular pathology and not the airway pathology. So more common causes of mosaic perfusion due to air trapping or small airways disease will be in asthma, in hypersensitivity pneumonitis, and in vascular diseases it will happen because of pulmonary embolism, chronic pulmonary embolism, pulmonary hypertension. So the point to be taken home is that mosaic perfusion is not always synonymous with obstructive vascular disease. Even air trapping in small airway disease is a component of what we see as mosaic perfusion or black areas. Look at this image. An expiratory image here is the key to diagnosis. A lung parenchyma which looks just mildly heterogeneous here in inspiration, and we have a doubt that there could be some gray and some black areas here. When we do the expiratory scan, everything becomes more and more clear, and you can see the heterogeneous attenuation and you can see air trapping, which could be because of the small airway disease resulting in mosaic perfusion. So how do we differentiate, or rather confirm, that the mosaic perfusion is because of airway and not because of vascular disease? The answer is to look in the airway. If you have air trapping and your airways show signs of airway involvement in the form of bronchial wall thickening, bronchiectasis, tree in bud, not tree in bus, patchy and lobular, well marginated and geographic in location, then it is mosaic perfusion due to airways. So here you can see that there are certain areas of air trapping. Look closely and you would see dilated airways. You can also see tree in bud. You may see air trapping. So air trapping with dilated airways with some tree in bud. This could be because of an on expiratory scan here, the mosaic perfusion here is probably airway related and not vascular related, because we can see there is some evidence of respiratory bronchiolitis, constrictive bronchiolitis, or any parenchymal lung involvement, like in hypersensitivity pneumonitis or bronchiectasis or asthma. If we want to rule out mosaic perfusion due to vascular disease, then we would have to look at the vasculature. Normally, you would see a dilated pulmonary artery. You can assess it by its size as compared to the ascending aorta. You may see enlarged segmental arteries. You may see bronchial artery hypertrophy, and you can see patches which are more confluent and more peripheral. Point to be taken home that usually due to vascular disease, you see a more peripherally lucent lung as compared to airway, where you could see more in the central lung. However, that's not absolute. Coming to the last part of today's talk about septal thickening. Septal thickening refers to interlobular septal thickening between various secondary pulmonary lobules or intralobular septal thickening within a pulmonary lobule. This is a secondary pulmonary lobule which has a pulmonary artery and the bronchus in the center with lymphatic surrounding it and the interlobular septa. Now, if this interlobular septa becomes thickened, it's called interlobular septal thickening. And if the intralobular structures, the peribronchovascular interstitium or the subpleural interstitium or the intralobular interstitium can also get affected. Septal thickening is seen as lines which are more prominent. So we can see these reticulations or these straight lines. This could be smooth, it could be irregular spiculated, or it could be nodular. Smooth interlobular septal thickening is usually the most common, but it is also the least specific of the three, and there are many conditions: venous, lymphatic, infiltrative, especially pulmonary edema, where you could get a smooth interlobular septal thickening. And if you look at this, there's a relatively smooth appearance, but all the pulmonary lobules, the septa, are thickened. So it could be smooth, it could be nodular, as classically described in the bronchovascular interstitium in sarcoidosis, and it could also be coarse or irregular, which happens usually in fibrotic lung diseases. We can also call it as reticulations or prominent reticular markings when you see intralobular and septal thickening and irregular interlobular thickening. It could be shaggy, irregular, corkscrew appearance, peripheral, and that's also called septal thickening. So prominent lines. Common differentials of septal thickening include interstitial edema, heart failure. They include lymphatic distensions and infiltration. If we divide them further in this category, you may have a symmetrical septal thickening as in pulmonary edema, sometimes also unilaterally more asymmetric in cardiogenic edema with pleural effusions. Lymphatic distension as in lymphangitis carcinomatosis is also very common and important differentiation in case your patient has a malignancy. There could be venous stasis in pulmonary vascular occlusive disease. It could be asymmetric, and sometimes you have associated findings like cardiomegaly, like presence of hilar lymph nodes in sarcoidosis, or a mediastinal mass lesion along with lymphangitis carcinomatosis that can help you distinguish. So I hope that you liked this video, and I encourage you to read more and also suggest me what you would want to hear in the coming more videos. Happy reading from Pulmonology Read Aloud. I'll meet you in another video. Bye bye.